Waiting to start for you to join us. Damn, Tony, I can't do this right. Please let me know if you can get on it. I just sent you the link. Now that the meeting has started, I have no idea. Did you receive? I emailed it to you. I have no idea how to get the password. Really sorry, but I don't know what else to do. The meeting needs to start. And I just sent you the invite link. How you doing, Tony?
Okay, you can hear me?
All right, cool. So let me invite everyone. We got 11 people or 10 people. So I'm going to admit everyone, okay? Ready?
Yeah.
All right, cool.
Did you want to?
Hello, everyone. I'm Dr. Epstein, and this is my partner, Tony Berred. It's a pleasure to have you join us on our webinar. Everyone's been muted. We suggest that if you have some questions to ask, because this is a relatively small group, we have the ability to unmute people at the end unless it grows in size. Or what you can do throughout the course of this webinar is to click on a chat button, which is on the bottom, and you can submit your questions by typing them in, and we will answer them as after we each make our presentation. Would you like to say anything, Tony?
Hi, everyone. I'm Dr. Barrett. I'm Dr. Epstein's partner. And I look forward to speaking with everyone about what my passion lies, which is rhinoplasty.
So anyway, Tony and I have worked together for 8 years. I've been in practice for close to 25 years. Tony joined me around a little over 8 years ago with a very strong pedigree in his training. He's been in practice for longer than 8 years, but he did, besides his ENT training, which, like me, at the University of Miami, he did a top rhinoplasty fellowship, facial plastic surgery fellowship in Chicago with a Dr. Dean Toriumi. And I recognize in Tony a passion that I felt would permit him to really become a rhinoplasty star. And those expectations have been met, if not exceeded. So I'm really proud to work with Tony together. There was a time we were doing equal numbers of noses, and then clearly he's doing more of them now, the majority of them for the practice. I still do some rhinoplasty work, but any of these particularly challenging cases or certain types of cases where I feel he'd be better off doing it, then I send them to him. And universally, I've been received a lot of appreciation from our patients after knowing that I sent them to the person who I felt would do the best job for them. So anyway, rhinoplasty is arguably the most complex and maybe even the pinnacle of plastic surgery procedures. It's very delicate surgery. It requires sculpting of the underlying structures and relying on that sculpting and other maneuvers to yield for a final result, which not only will look good a couple of weeks, after the surgery, but will stay looking natural looking and aesthetic for many years. We both use computer imaging to help our patients visualize what we anticipate will be the outcome of the procedure. It's part of the process. We don't really use computer imaging to sell our surgery, not at all. We actually use it more to educate ourselves as much as educate our patients. Anyway, Tony, why don't you talk for a while and then just save me a little bit of time to talk a little bit about the questions. And then also, I will welcome any new participants. Yeah, so I'll let you go ahead and take it over, Tony.
I appreciate it, Jeff. Please forgive any kids yelling or dogs barking as I'm doing this from home. But thank you, everyone, for joining us. Like I mentioned, rhinoplasty is my passion. I've been doing this procedure now for 10 years, plus my residency, so close to 15 years now, since 2005. And I've appreciated, like Dr. Epstein just mentioned, the same appreciation that I started to develop many years ago has just been fostered because of the complexity of the surgery. I'm always pushing myself. I'm always challenging myself to get better and better and better as a surgeon. It's amazing how the procedure has evolved, not only in my hands, but even globally. As I attend and lecture at meetings annually, I've seen the techniques change throughout the years. Although there have been some dramatic giant leaps forward in some of the things that I've been doing in the course of my practice, there are some more subtle refinements and techniques that I've evolved and developed. And I've really felt I've been in the best interest of my patients. And I'm constantly, particularly now with the downtime and the stoppage of my surgery, constantly educating myself on the latest research, as well as looking back. I'm my own hardest critic, as Dr. Epstein, I can attest to as well. I spend my time looking back on my patients, looking back on my techniques. I take a lot of photography, both in surgery, before and after as well, to visually educate myself as to, where refinements can be made and how the technique can be further improved. So I just want to start, that's just a little bit of a background as to where my passion lies. I wanted to start with basically just some basic aesthetics in both the male and female nose as I've seen it. So I'm going to try to share my screen here. Hopefully this works here. So what I wanted to start with is basically the female bridge and how it differs from the male bridge and how we look at it. This is an ethnic rhinoplasty case. Within rhinoplasty, obviously ethnic rhinoplasty, and I hope you can see this screen. Within rhinoplasty, every patient poses a unique anatomy. Of course, I've had the fortune of practicing not only in Miami, but I did my training in Chicago. So it's been a very, I've seen a lot of patients of multiple ethnicities. I do a lot of ethnic rhinoplasty, a lot of Hispanic cases, patients of Asian descent, and as well as Caucasian and like I mentioned, Hispanic patients. So the female profile aesthetics differ from the male profile aesthetics in most patients. And again, Dr. Epstein alluded to communicating mutual goals for surgery. And I'm a firm believer in computerized imaging, not like Dr. Epstein mentioned, not as a sales tool, but rather to openly communicate what the goals are for surgery. So what are the patient's goals for surgery? I show them what I feel could be realistic and aesthetic in their case. And then I use that computerized image to further communicate as to what the patient may desire, what they do or they don't like about the surgery or about the proposed outcome. I'm not a fan of necessarily continuing to revise computerized imaging because like I mentioned, I use it as a means of communication. So it's obviously easier to morph computerized photos. And I always tell patients, you're not made of patients are not made of clay or wood, unfortunately. So the computerized imaging serves as a basis of how, let's say, they perceive their bridge or how they want their bridge to be. But in general, the female aesthetic, has a more of a slightly a slope to the bridge. I'm not a fan of creating a very ski sloped bridge, as was popularized with rhinoplasty many years ago, which lends itself, especially over time, to give a very unnatural appearance. But although my aesthetic preference is to give a very natural outcome, and by doing so, creating a nice, gentle, maybe a straighter to a slightly sloped bridge, as in this case of an African-American patient who perceived herself as having a bump. And in this case, which is interesting, it's not a matter of this patient presents themselves and they come in and they say they want to reduce the bump. But in this case, it's not a matter of necessarily reducing the bump. It is to a degree, but most of it in a case like this, especially in someone with thicker skin, you have to project the tip. Projection meaning push it outwards. And you have to bring down this bump and at the same time elevate the radix a little bit so you get this nice natural curvature to the profile and give it a very natural looking result as opposed to it looking very ski sloped. Another patient, female patient, this is her before from the frontal view, came in with the concerns. I'm sorry, I'm having issues with concerns with her tip from the front, but mostly her concerns were from the profile view. She also wanted a nice natural outcome, a gentle slope. So obviously, not only the bridge has to be refined in her case, but also the tip, because the bridge and tip aesthetics go hand in hand. So in her case, from the front view, we were able to create these refinements to the front of the nose by reshaping the tip so that it appears narrower without creating a very pinched look, because we don't want to bring this out to a point but we want to create a nice soft oval shape, like I referred to the tip aesthetics, so that it appears natural, doesn't appear pointed from the front. And then this lends itself to the profile view, similar to the profile that I showed earlier of, you know, a straighter bridge, a nice gentle slope to the nose, a slight lifting of the tip, but still preserving a very natural appearance. Now, switching to male profile aesthetics. Male profile aesthetics tend to be a little bit more, it's a little different. This young man came in with the concerns of an over-projected nose, a larger nose, a projected tip, projected bridge as well. So this is what's referred to as a very complicated case, actually, is referred to as a tension nose. Basically, you have an overgrowth, it's under tension, overgrowth of the bone, overgrowth of the cartilage, overgrowth of this cartilage and bone down here. So in his case, we've set back the nose pretty considerably in his case, and then also supported and raised the tip, but at the same time, keeping a very strong profile. Although it's a much smaller nose, we're still able to preserve a very strong, straight profile in him, which is different, like you may notice, from the other two previous patients. And again, I wanted to show another example of a male with a large over-projected bridge and nose as well. We're setting back the nose, setting back the tip. And this is a rather involved maneuver that I perform, because it's not just a matter of bringing in the nose, or what's called deprojecting the nose, but I've actually brought back the nose to such a degree that I've created more of an acute angle. As you could see, it's subtle, but his upper lip has actually lengthened in this case, because of the fact that I was able to bring in the tip and reset the projection of the nose. I actually set back the tip cartilages back onto his bone here so much that his tip was actually able to lengthen and his nose was actually able to relax. And this is another case, male aesthetics, which are different, like I alluded to from the aesthetics that I showed earlier. Jeff, do you want to intervene or interject at all at any point, or?
No, Tony, you can talk, go for another 10, 15 minutes. That's fine, it's beautiful work.
I'm just going through some examples of
Great.
some, you know, quote unquote cases here, classic cases. This is completely switching gears here. I just wanted to, you know, demonstrate, if you will, you know, the various noses that I perform. You know, they're not just all the same. Obviously, everyone's anatomy is completely different based on, you know, their ethnic background and so forth, skin thickness, nasal bone shape. This patient has the complete opposite problem, right? Or as a complete opposite concern than the other patients. Instead of having a large nose, or instead of having an over-projected nose, she felt like she had a very short nose and had no bridge, had no definition. She came to me and said, "I'm all tip. I've got no bridge." And this is a patient of Hispanic as well as of African descent. And in her case, what we did was we actually, to create refinements to the front of the nose, we actually had to build up the nose, right? Which is the opposite of what I was referring to earlier. Now we're not reducing the nose, we're actually building the nose. So this is the complete opposite end of the spectrum, if you will, as far as I'm sorry here. Oh, my screen froze. My screen froze here. One second. Okay. All right. So this is her, you know, changes that we see from the front, you know, able to, you know, reduce, you know, some of the bulbosity, the thickness to the tip, able to change the configuration of her nostrils a little bit, but mostly building up her bridge. And again, you can see the before and after. This is the opposite, right? We're actually building up the nose to create these refinements to the front. We're actually building up the nose from the profile view. So in her case, I don't use implants in the nose. I actually, in her case, use cartilage from the ear. It's a technique that I've developed and I've almost, I've really truly fallen in love with it over the last couple of years, just because of the results I've been able to get with it using natural cartilage. So I built up her bridge and I projected her bridge to create those refinements in 3 dimensions that I showed you in the frontal view. Another example, these are more complicated cases. These aren't your easy rhinoplasties. Not that any of them are easy, but in this case, this patient, her concerns were mostly the profile, but you always have to treat the nose obviously in 3 dimensions. So what you see in the front affects what you see in the side. So in her case, her concerns were of the profile view. She felt like she had a bump. She felt like her tip was droopy. So we have to look at the frontal view, and we have to preserve the natural appearance to the frontal view, because it's one thing to just raise this tip and bring it out to a point and bring down this hump. But in her case, we have to consider the shape of her cartilages. And in her case, what I've done is actually a little bit more of an advanced technique, which is called repositioning of the tip cartilages, where I don't just suture the tip cartilages together to make the tip smaller. I actually flatten them and what's referred to as reposition them, bring them down to change the shape and also create refinements. So in her case, to preserve the natural appearance to the tip, she wasn't as concerned as creating a narrow tip in her case, but you have to consider this in 3 dimensions. So what I did in her case was I repositioned her tip cartilages to preserve that natural horizontal oval shape to the tip and now bring it out to a very pinched look, which is very easy to do in this case. You could fall into that trap as a surgeon to pinch this patient's nose. So we have to preserve that soft, as you can see from her tip highlight points here. It's a very, this tip highlight point, this white here, it's showing you like a horizontal shape to the tip. And it's basically, the tip has been shortened. This part of the nose down here called the columella has been brought in to create a smaller quote unquote tip. And then what this did was it translated to the profile view into, the raising of the tip and of course, achieving her goals from the profile. But again, it goes hand in hand. What you do in the side, you have to think about what you're doing in the front as well. Switching gears a little bit, this is a Hispanic patient as opposed to the Caucasian female that we saw earlier or just now. This is a patient that came in with the primary concern of the wideness, what's called the bulbosity of her tip. And again, from the profile, she again was concerned about the bump and the droopy appearance to the tip. So again, in her case, I look at these cases to be very challenging because we want to maximize the refinements to the front of this girl's nose, but at the same time preserve a very natural result. So again, this isn't a matter of just bringing in these tip cartilages or suturing or stitching these tip cartilages together or shaving them down, because that could lead to a very pinched tip, a very pointy tip, over resected, what we refer to as overdone look, which looks very operated on. So to achieve her concerns as well, her tip cartilages were repositioned as well. So what I was able to do in this case as well was to bring her tip highlight points down here like they are earlier, but remove this fullness on the outside of the nose to create a very soft, what's called brow tip aesthetic line. So this line here, if you could see my pointer, is referred to as the brow tip aesthetic line. In her case, it comes down here and then it comes out around the tip. So you want to preserve this really nice soft curvature to the nose so that it comes out to a nice soft oval, horizontal oval shape to the tip of the nose and give it a very natural look. And then how this reflects into the profile view as well to achieve her goals. We bring down the bump, but again, it's not so much as bringing down the bump in her case as it is in refining her tip cartilage to give it a very soft, natural appearance so it doesn't look overdone or operated on, to give a natural result. And then I'll finish with a couple more cases. These are more complicated, crooked noses. Whole other ball game here when you're dealing with crooked noses. Crooked noses are thought to be within rhinoplasty some of the hardest within primary rhinoplasty. So this young girl, again, has a very crooked nose, as you can see here off to the right. She was born this way. When you're born with something, it's called congenital. So she had this congenital deviation to the nose. So to do these cases, I'm very aggressive with these because I've learned, again, through the years, through the last 10, 15 years I've been doing this surgery, that you can't take a minimalist approach with crooked noses because they'll stay crooked. So to get the best outcome, I perform a top to bottom reconstruction of the nose. I do asymmetric osteotomies, meaning what I do on the right side on the bones is completely different than what I do on the left side. On this right side, I've actually brought in the bone, and on the left side, I've actually will push out the bone. What I do to the middle third of the nose, which is this part of the nose here, I actually do what are called spreader grafts, which are cartilage grafts, which help to straighten the middle third of the nose. But in addition to that, I perform these clocking sutures, which is basically where I take a stitch from this side and I literally pull a nose over towards the left side. Again, a very aggressive approach, but I found it to be invaluable with crooked noses. And then the last area is the tip. You have to treat the tip completely differently. I've repositioned the tip. The tip is completely independent of the middle third of the nose, so you have to treat the tip differently. So in this patient, I've been able to, straighten the nose, in her case, by bringing these cartilages over, bringing the tip cartilages over, and at the same time achieving her goals aesthetically, which were not only the deviation of the nose, but also to give the tip some more refinement and also narrow and straighten the bridge. And then also lastly, from the profile view, again, achieving her concerns by reducing the bump and slightly elevating the tip. Again, not an easy case. And I'll end with a male rhinoplasty patient with a crooked nose. His was related to a series of trauma, but at the same time, born with some deviation to the nose. He said he had noticed this his entire life, as he said. So his concerns were the deviations of the nose towards the left side. Different techniques. I'm not going to belabor what I do with this, but again, I take a very aggressive approach to give the patient the benefit of the doubt. I'm not saying I'm perfect in these cases because they're extremely difficult, but nonetheless, to give the patient the benefit of maximizing the straightness to the nose, I'm very aggressive with these procedures. And again, in this case, we were able to straighten his nose, which was significantly deviated. And within this, is funny, crooked noses started my passion with rhinoplasty because they're so challenging. And through the years, my techniques have refined themselves to try to maximize the results for the patients. So again, I just wanted to show different procedures, different patients of different ethnicities, male, female patients. As a rhinoplasty patient, isn't just obviously done on one specific anatomy. Patients come in with different concerns and different goals, and we have to individualize our treatment plan for everyone. Thank you.
Tony, that was great. Every time I see your work, I'm impressed. Those are not easy to achieve, especially with consistency. And I think that it's important to recognize that certain steps, extra steps, need to be taken to have consistency in rhinoplasty, because every surgeon can have, a handful of cases that are, come out nice, but to have all those different cases and to consistently produce the kind of results. Any thoughts about that, Tony, in terms of, what are particular steps that you feel are necessary to have reliable results?
It's funny because I've been thinking about a lot of that now in the circumstances we find ourselves in. Like I alluded to earlier, I am a constant student of this surgery and a constant student of my own results. As you know, I take a lot of photos. I take a detailed diagram of everything that I do in surgery for my own knowledge, for my own edification. So what I have found and to be very helpful for me is okay, what have I done in this specific case, and how has it turned out 6, 9, 12 months after the surgery? And given the, now, hundreds, if not 1,000 cases that I've done already, I found that being so self-critical and analyzing my surgical techniques has really I found to have developed more consistency in my results using that approach.
Tony, would you describe rhinoplasty as more aesthetic or technical? Or what balance, how does it fit in, and how does that compare to other plastic surgery procedures, facial plastic
Yeah,
procedures?
I think obviously, it's obviously a bit of both. I think that I think aesthetically, it's open, communication. As far as, we all have aesthetic goals if we have concerns, obviously, about our noses. So the element of the artistic component of it goes so far. Then you have to be very technical. Because the artistic component, allows you to develop a picture in your mind. And that's why I love computerized imaging. And it's been a beautiful tool that's been developed because it allows you to convey to the patient what's going on in your mind as far as what we could artistically achieve. But then just your dexterity and your technical ability takes over. It's a very, very technical, very complex as far as dexterity and ability, surgically ability. So I think if I had to give it a percentage, Jeff, I would probably say 30% artistic and 70% technical.
When you started working with me 8 years ago, these cases used to take you quite a bit longer. You're obviously more efficient, yet I think obviously you're happier with the results today than you were, like we all are. How would you explain that?
It's different. I wouldn't say, and I've had this conversation with a lot of surgeons, rhinoplasty surgeons, who are, with a lot of experience, a lot more experience than myself. Where I spend my time in surgery is different. So I wouldn't say that necessarily my surgical times have gone down. Like I tell patients, I'm in there to give you the best possible result. My goal is to give you the best possible result that I humanly can, given your anatomy and given my ability, right, in that surgery. So obviously 8 years ago, 9, 10 years ago, where I spend my time in surgery was probably more in the actual technical aspects of the procedure, whereas now I spend a lot more time in the minutia, because I've noticed through the years that to go from, like the book says, from good to great, you've got to focus on the minutia. So I spend a lot of time using, soft tissue grafts, which I take from the nose. And what that does is just helps me to camouflage any potential irregularities or asymmetries, which could come up in any surgery in the future. Not to say that we can obviate, but those asymmetries or irregularities, but we can take more measures to camouflage that. And it's funny because I did notice that, looking back on my residency and my fellowship 10 years ago, like you alluded to, my mentor in rhinoplasty, he would spend an hour of the surgery on these like subtle details that, 11 years ago I wasn't seeing, but now I see them. And now I know why he spent the time in those subtle details of the procedure. Because there's a difference between a good rhinoplasty and great rhinoplasty with consistent results.
Interesting. When you talk about the fine details, would you talk about one of the questions we got asked is how do you deal with thick skin, particularly in patients of African ethnicity? I know we both talk about this in different approaches, not just the steroid injections afterwards, but defatting of the skin. What are some of the other things that you feel you need to do with to deal with thicker skin?
The way I explain it to patients that have thicker skin is it's like a thick blanket. So ironically or counterintuitively, I guess I should say, sometimes we need to build up the nose to create more refinements, in the sense that we have to look at the nose in 3 dimensions. So when we have a thicker covering, when we have thicker skin, we can't reduce the bones and reduce the cartilages and expect the nose to appear thinner, because that just creates thicker skin. So you're basically bringing down the support underneath that thicker covering. So in patients with thicker skin, yes, you can defat the skin and that helps to an extent, but you have to create and you have to have adequate support of the bones, of the bridge, and of the tip. If you don't have that support from the perspective of the profile, you won't develop the refinements that you're seeking from the frontal view.
I like to analogize it to a tent.
Yeah.
If you have a tent, you think of the skin as the canvas, and the tent is the hip cartilages, or basically all the cartilages. And if you have a tent pole that's all the way suspended, you're going to have a nice defined pointy tip, relatively speaking. If you let that tent pole slide back down, the canvas is just going to bunch around. So it's the same concept. You can cut away all the inside material, but actually many times, as you said, I use the term counterintuitive, you actually want to increase tip projection a bit and increase the strength, which may require adding cartilage. Doesn't necessarily mean it's going to be fatter. It's just that you're having better support, and therefore that overlying skin can lay nicer. Would you sort of agree with that analogy?
Oh, exactly. I use that analogy a lot as well. I use the analogy of a thick blanket. So the more you push into that blanket, if you were to stick your hand underneath a thicker blanket, obviously if your hand's down on the base of the bed, you're not going to see your hand. But as you project into that, you're going to see more of the underlying structure, and that's what you need to do with thick skin patients.
Great. Let me present a couple of cases as well, but I hope I'm, let me see. Where's my presentation? Sorry about that. Yeah, it's right there. Sorry about that. I'm going to share. I'm hitting share screen. Oh, Tony, are you still sharing or no? Huh, I'm
No,
so
I'm not.
sorry. For some reason, why don't you talk for a couple of minutes, Tony? I'm gonna try to figure this out.
Yeah, there were some questions that I see pop up on my screen of crooked noses, and that being the most difficult of all, frankly, of all primary cases. Revisions is another beast, if you will. But crooked noses, again, a lot of them are due to one of two things. So my first assessment on history taking is whether the crooked nose is due to trauma or congenital, like I mentioned, meaning that you were born with it. We're all born with a degree of asymmetries to our noses. Now, some more than others. Obviously, some are born with some natural deviations. We don't know why, but just some patients have a naturally deviated nose. Those are more challenging than noses that were crooked because of trauma. It's working, Jeff. So when I see patients, and I do a lot of congenitally crooked noses, basically we're reversing something that was, naturally given. So those require a lot more of an aggressive approach than we would if somebody, whether the deviation was related to trauma, such as, sports-related injury or so forth. Jeff, it's working.
Great. If it's all right, let me just talk about,
Yep.
I'm just going to show a couple of cases as well. Another typically ethnic type nose, some of the classic features are lack of definition of the tip. In this case, the patient has a overprojected dorsum or bump. When she smiles, her tip droops a bit due to soft support or inadequate support of the tip cartilages. This was her after, by rotating the tip up, but increasing slightly its projection, taking down its bump, and creating a more refined look. So you can see the before and the after. The tip is a bit projected, but this is the only way to maintain that projection when she smiles, so it doesn't droop anymore. And so basically what I did was basically rebuild the tip through an open approach to create better support. Here's another similar type nose, but thinner skin, a slight bump. In this case, the tip was not downwardly rotated, but she had pretty good projection, but she was mainly concerned about the asymmetry as well as the lack of definition. And you can see the before and the after on profile. So the tip was actually built up a bit. This is sort of my signature. I like to have a super tip break. And you can see the before and the after from frontal view. Her nose is straighter. And now you can see much more clearly a tip defining point, which is not actually a point, but it's actually a little zone of where the tip is. Another case of a patient before, I just showing her before and after. She had a little bit of a, once again, a bump. The nasal labial angle, the angle which the columella makes with the upper lip, I rotated up, particularly on the distal tip. I opened it up to create a little bit of an upward tip. In this case, this patient also got a chin implant, a small chin implant. I feel that there is a role for that. However, chin implants are not in and of itself a replacement for making a nose look prettier, but they can create a slightly nicer aesthetic appearance. And you can see her before and after. She had a cleft columella. She was asymmetric, and here the tip is more diamond shaped as opposed to more circular. This is a revision case. Patient had an orthoresection of tip cartilages. When I opened her up, there was very little of her own natural cartilage left. So in this case, I had to use her ear cartilage to basically rebuild this whole left tip. And you can see the results that I was able to achieve. Also reset the bridge to help make it a straighter look. And you can see her profile before, very little tip support. These tip cartilage were basically free hanging, and here the tip's been secured using, in this case, ear cartilage. There should be no deformity of the ear when we do use ear cartilage. The reason why the ear cartilage had to be used is because so much of her septal cartilage had already been resected with her first surgery. Personally, when I see a patient that had a prior rhinoplasty that they're seeking to have repaired, when that prior rhinoplasty was done by a general plastic surgeon, I'm much happier or much more optimistic than if it was done by a facial plastic surgeon, because facial plastic surgeons with our background in ear, nose, and throat generally use septal cartilage. May not have been used properly, but they tend to use septal cartilage as opposed to general plastic surgeons. Many times don't like to go into the septum. If they'll use any cartilage, they'll go ahead and they will use cartilage from the ear. And I prefer septal cartilage, so having that available is always preferable. Here's another patient, a gentleman, somewhat thick skin, a lack of definition of his tip. When he smiles, his tip droops, columella is asymmetric. You're not going to prevent the nostrils from completely flaring, but when you have better tip support, the tip will be less likely to get pulled back, so therefore the nostrils will tend not to widen as much. And here you can see the before and the after. I did increase his tip projection a bit, but also a much stronger tip. I didn't have to do any takedown of his bump other than a little bit up here and a little bit here, but mainly this is due to the increase in tip projection, creating a nicer looking nose, not necessarily a smaller nose, but a nicer looking nose. This is a lecture I gave on Afro-Caribbean patients. It was done in Germany, Munich, Germany. I talk about with the Platyrrhine or the African typical Afro-Caribbean nose, which is primarily weak tip support, poor tip projection, thick skin. And you can see before 1 month and 4 months after how the nose has become more refined. With healing, the skin will thin out. In addition, doing injections of steroids will facilitate that. This is a girl before and after. Some of the features you presented, Tony, where the nose was actually quite short, I was able to not just lengthen or increase the height of the nose, but also I was able to build up her nose, her bridge. Primarily, I built up her tip, but I did do some building up of the dorsum as well. And you can see the before and the after, and you can see the base view, the before and the after, how it's much more, instead of this being, the nostrils being round, they're much more oblong in shape. And here's one last case of before and an after of a refinement. I did some nostril narrowing, but also built up the tip cartilages, reset the bridge, and you can see when she smiles, the nostrils don't flare as much. So that's what I have with regards to some of these cases with both some of my cases I like to present. I do have a couple of questions, and one of the questions, the use of Gore-Tex implants. When should it be used? I use my Gore-Tex. I'm a bigger fan of Gore-Tex preformed nasal implants. I like to use it for building up the dorsum. It is permanent. Gore-Tex has been used for, I've been personally using Gore-Tex for over 27 years in the nose. It's basically inert, which means the body does not recognize it as anything other than itself. It feels natural, particularly these preformed implants can create a nice building up of the dorsum. Your thoughts, Tony?
Yeah, obviously I differ a little bit. I try to use natural cartilage in the nose. I think I find that aesthetically I can achieve the same results with having used both in the past. It's not like I don't exclusively use natural cartilage. I've definitely done a few cases through the years on patients that have requested or have been adamant about using an implant in the nose, and I have used those in the past. So I'm familiar with the two aesthetically since I haven't found the difference. For me and my hands, my preference is to use natural cartilage. Now that has evolved through the years. What I was doing 10 years ago is definitely not what I'm doing now. I've evolved from what was a solid implant. I used to use rib, referred to as costal cartilage, as a solid implant in the nose, and that's initially how I was trained to do it. I was having concerns with it in the way it appeared to patients, especially over time. In fact, no one really complained to me, although I could see it where the edges were starting to be a little bit more visible through the years. So I switched then to dice cartilage. As you know, my technique with dice cartilage has evolved as well. You mentioned the meeting that we attended in Germany that we spoke at. I actually, a few years ago, attended the meeting with Dr. Epstein, and we went to an international meeting in Germany. And I switched at that point from using dice cartilage wrapped in what's called temporalis fascia, which is the fascia that we have here on the side of our head. And I switched from that to using a sealant, which is a natural fibrin. And I've been using that instead. And I've been able to mold the grafts better to make them look like a dorsal bridge. So the results have been extremely natural. It's one less incision for the patient, so it's a little less morbid for the patient. I've been having aesthetically some really nice results with it. And again, my thoughts are, it's not, an implant, so it obviates any potential risk associated with that.
Very cool. Tony, do you discriminate? Here's a question. Actually, let me ask, do you discriminate pure crooked noses versus deviated noses on an asymmetric midface? How do you discriminate pure crooked noses versus deviated noses on an asymmetric midface?
There's two things. Number one, that's a great question. The analysis of a crooked nose entails not only the nose, but facial symmetry. And we all have, like I mentioned, they've done actually split face analysis on people. It's actually pretty fun if you haven't done it on yourself. But if you were to actually take your face and then just mirror image one side of your face to the other, you wouldn't look like yourself. So the reason, in fact, facial harmony and facial beauty comes from subtle asymmetries that we all have. So I look at the face holistically and I analyze all my photos. I take a frontal view photo that I take in front of my photo board, and then I actually bifurcate the face by measuring the interpupillary distance. I do this for every single case that I perform. It's just a habit I've gotten into. And what I do is then I drop a line in between that point, and that helps me to see what a lot of patients don't see in themselves, which is what's causing the crookedness to the nose. So from that, we break the nose down into the nasal bones, like I mentioned earlier. the middle third of the nose, which is called the middle vault, and the nasal tip. And I look at those, not only thirds, upper third, middle third, and lower third, and how that's contributing to the crookedness of the deviation, but rather left and right. So what's causing these asymmetries? And by looking at it, and doing that exercise pretty much with every case, and particularly with crooked noses, it really helps you to diagnose the cause of the deviation or the cause of the crookedness. And again, just like in any aspect of healthcare and medicine, you start with a diagnosis, and starting with the proper diagnosis of a crooked nose allows for more success rate with correction of the deviation.
Got another question for you. Someone said, by the way, amazing work, Tony. Does computer imaging show potential rhino results 3 months post-op, 1 year post? What do you advise?
Good question. In fact, when I reply, I always reply to computer imaging. I never do it in person. What I do is I dedicate the time during the consultation, along with my patient coordinator, to taking a proper history, performing a physical examination, and of course, communicating our goals. I then take the photos all myself from multiple angles. Then I perform the computer imaging separately. After the consultation, I take the time at the end of each day to go back, review the photos, analyze the photos, and perform the computerized imaging. When I send out the imaging, I email patients the digital images, and I always say in that email that these results are after the swelling has mostly subsided. So what that means is that the results are not the results you would come to expect 1, 3 months, 6 months down the road, but what I feel would be the aesthetic and realistic results 9, 12, and in some cases, especially in patients of thicker skin, that could be 1.5 years to even up to 2 years after the procedure, depending on the healing of the person. So it is after the swelling has mostly resolved.
Great. Got another one. I jumped on late, so I'm sorry if this was already addressed. It wasn't. Are tips of the nose the hardest to correct? Pointy or rather long nose tips, ways to go about correcting it. I'm going to jump on this one, so to speak. Tips are, there's no easy part of our nose to get consistent results. In general, achieving naturalness in the tip and the aesthetic look is probably the area we focus more of our time. It's, so it is, I would say, a bit more, I'd say it's probably that, making a crooked nose perfectly straight and creating a really natural looking symmetric tip are probably the 2 biggest challenges. When tips that you describe, pointy or rather long tips or over projected, many times it's easier actually to deproject a tip than to increase the projection. And there are several ways to do that, but it's not what, you don't just cut the cartilage away, we actually shape them, move them, slide them along. So for example, what is the tip? These, what's called the columella, where the tip cartilages come together, we can increase how far out they stick back or set them back. Any thoughts you want to add to that, Tony, regarding tips and pointy tips and the challenges there?
Yeah, I'll show, give me a second here, I'm gonna, yeah, I do think tips are the hardest part of the nose, because it's I think a part of the nose where we deal, obviously we deal with it in the entire nose, but we do deal with it, the 3-dimensionality of the nose is particularly evident in the tip. So it's very easy. I'm hoping I'm able to share my screen, I think.
Yeah, it's showing.
Yeah, so I just grabbed this patient real fast as you were talking, Jeff, because I think it draws on this example. This is a revision of a patient with an overprojected pointy nose. So in her case, she was dissatisfied with the length of the nose, the pointiness of the nose. And the reason this happened in the primary surgery was because the focus is on the front of the nose, meaning that she went in and she asked that her nose, appears less wide, appears less pointy, appears less bulbous from the front. So of course, to do that, you create refinements, and like we alluded to, and oftentimes you you project the tip to create these refinements. But so what happened in her case, that yeah, she got a very narrow nose, she got a very pointy tip. You know, I mean, I'm not even going to go into the middle vault and the middle third of the nose, but yeah, she was able to achieve these refinements and these significant narrowing. I don't have her, obviously, her original photos, but she was able to create these refinements to the front. But the problem is it was brought out to a point. So that's why I tend to perform a lot of what's called repositioning in cases such as hers, because it allows me to deconstruct the tip in 3 dimensions and to create refinements without necessarily changing the angle of the side nose, the side of the nose. So in her case, I've actually, you know, softened the tip. I actually, you know, widened the tip, if you will, just to create a more of a horizontal oval aesthetic, as I alluded to earlier. Instead of it coming out to a solid point like she had in her primary, it comes out to more of a horizontal oval, you know, soft football shape, to allow a more natural look. Still, she has a very thin tip. You know, I feel like she has a very refined tip. She was really happy with this tip aesthetic. But what it allowed me to do was to set back the tip so it appears softer from the profile, elevated, shorter, and less pointy. Okay.
Great.
Thank you.
Great example. I think that's all we have. Oh, we got one more message. Well, this will be our last question. What type of sutures do you use for the tip sculpting dorsal reconstruction? I'll let you take it away, Tony.
This is something, again, that has evolved for tip sculpting. I don't have a diagram for you to show of what I do, and I'm not gonna, I'll spare you guys from showing intraoperative anatomy. But basically, what I do with this tip suturing technique is I do not bring the tips to a point. It's very simple to bring the tip cartilages, and this is what's done in a lot of rhinoplasty. Is, you know, these are your tip points. So what do? You bring them together and you bring them down to a point to create these refinements, if you will, okay, to create narrowing. Instead of doing that, I actually perform a suturing technique, which I like to refer to as repositioning of the orientation of the tip, as opposed to significant narrowing of the tip point feature. So I use what are called intradomal sutures, if you want specifics, which means that I individualize sutures. I don't put a suture from one tip cartilage into the other tip cartilage. I separate the tip sutures, and I reorient the tip cartilages using these types of sutures. I hope that answered your question.
Great. Well, perfect timing. 1 hour. I like to keep them this length. Tony, I love talking with you. I just thought, you was thinking, wouldn't it be cool to have these sort of discussions on a regular basis? Right?
Yeah. Sorry about that. As my dog barks. I would love to do these more often.
Yeah. So please, if you have any questions, right now, obviously, we're not doing surgeries, but we are doing webcams for and also photo reviews. But please, if you ever have questions, please feel free to email us. Dr. Bared's website is dranthonybared.com. And you're always welcome to call the office for an appointment. Anything else you want to say, Tony? Besides, I'm going to tell you, thank you so much for.
No, thank you. Thank you for your time, for everyone listening. Appreciate it.
All right. Have a good evening. Stay safe and healthy, everyone. Hey, how are you, Constantine? Nice to see you. Okay, bye, guys. Good night.